Okay, everyone, good evening. My name is Mandy Stone, and welcome to Southern Medical Association's first Bone Club meeting. First on the list is to be aware that the webinar tonight is being recorded, and we may use this activity tonight in a future CME activity online. Regarding your CME credit, tomorrow everyone will receive an email with a link, and we ask that you evaluate the session, and we want you to give us future ideas for future webinars on osteoporosis, and there will also be a place for you to claim your CME credit. Once you submit that information, we will process your certificate and email it to you in about a week after you submit the information. And tonight, your participation in the session is very important. And I have everybody muted except for the speakers right now to avoid background noises that may distract you from listening. But throughout the presentation, we'll be monitoring the chat box. You'll notice on your menu item that there is a box where you can ask questions, and we will be monitoring that. And during the discussion time, you can use the icon on the control panel to raise your hand to indicate that you have a question or comment, and we will recognize you when you raise your hand and unmute your line so that you can ask your question. And later in the program, we will probably just unmute everyone and give everyone the opportunity to interact with the faculty and talk and so forth. So anyway, we thank you for being here tonight, and I am going to turn the screen over to Dr. Hamdy and let him begin the program.
Well, hello, good evening to everybody, and thank you for joining us. I'm delighted that so many of you have decided to join us in this new experiment that we haven't done before, a webinar on a bone club. And tonight's focus is going to be on osteonecrosis of the jaw. I first would like to recognize my collaborators. And my co-chair is Dr. Sanford Baim. Dr. Baim is the Director of Bone Metabolic Diseases in the Division of Endocrinology and Metabolism at Rush University Medical Center, Chicago. He is one of the past presidents of the International Society of Clinical Densitometry and has been extraordinarily active in the field of osteoporosis and bone diseases. It really is my privilege to have him as co-moderator with me. Dr. Baim has no financial relationship to disclose. I'm also delighted to have Dr. Aliya Khan, who's Professor of Clinical Medicine in the Divisions of Endocrinology and Geriatrics at McMaster University, and is the co-chair of the International Task Force on Osteonecrosis of the jaw. I'm sure most of you by now would have recognized that she is the first author of a paper, a review paper on osteonecrosis of the jaw that was published in January in the Journal of the Bone and Mineral Research. Dr. Khan has no relevant financial relationship to discuss, and she will discuss novel agents in the treatment of osteonecrosis of the jaw, modalities that are not yet approved by the FDA. And finally, it gives me great pleasure to introduce Dr. Archie Morrison, who's Associate Professor of Oral and Maxillofacial Surgery at Dalhousie University and the QE2 HSC. He's also the co-chair of the International Task Force on Osteonecrosis of the jaw in Halifax, Nova Scotia. Like the other speakers and moderators, Dr. Morrison has no financial relationship to disclose. Our learning objectives. Mandy, I'm afraid I've lost my slides, so maybe you can navigate for me. The learning objectives of this session are fairly straightforward. We hope that upon completion of this webinar, participants should be able to first identify the incidence of osteonecrosis of the jaw in patients with osteoporosis on anti-resorptive medication, and to differentiate this incidence from that in patients with neoplasia. The second objective is to identify the factors that increase the risk of ONJ. Third objective is to know the relationship between ONJ and anti-resorptive therapy. We also hope to cover the diagnosis, stages, and management of osteoporosis of the jaw And the last objective is to know when to refer a patient with ONJ or potential ONJ to a dentist or oral surgeon. In the next slide, you have the agenda. It is fairly straightforward, and I hope you'll be able to follow it. Just a reminder, the Southern Medical Association is accredited by the Accreditation Council for continuing medical education to provide continuing medical education for physicians, and you can earn a 1 AMA PRA credit 1 for following this. Sessions like this, as you all know, do not generate spontaneously. It takes a lot of very hard work and preparation. I'm delighted to have been able to work with the 3 other speakers and moderators. I also would like very especially to recognize all the work that Mandy Stone has done. She's the one who's been spearheading this program. She works with the Southern Medical Association. And also the person in the shadow, Randy Glick, who's the CEO of the Southern Medical Association, and he's been instrumental in developing this program. One last issue before we go on to the discussion. As you've already heard from Mandy, this webinar is being recorded. So without any further ado, let's talk about our case. Okay, so the case we're going to discuss today is a 64-year-old woman. She wants to have 4 dental implants. However, the dentist is reluctant to proceed. She has been on alendronate for 8 years. She complies well with the intake of the medication and is on no other medication. Her initial baseline T-score about 8 years ago was -3 in the lumbar vertebrae. Factors predisposing to osteoporosis in her case include a surgical menopause when she was 31 years old, and she has not been on hormonal replacement therapy. She has a positive family history for osteoporosis. Her mother has sustained a fragility hip fracture. Her daily calcium intake is also low. Secondary cause of osteoporosis had been ruled out. During this 8-year period, her BMD gradually increased by 12.2%. Now her T-score of the upper 4 lumbar vertebrae is -2.6. She is asymptomatic. Her gums appear to be healthy. Various laboratory tests, including the comprehensive metabolic profile and vitamin D levels, are normal. So this is the case, and the patient comes to us because she really very much would like to have these implants to go ahead, but unfortunately the dentist is reluctant to proceed. Let me first ask Dr. Archie Morrison. Archie, what do you think about this scenario? What do you think about the dentist saying, no, I'm not going to operate on you?
And I presume she's edentulous, is she? She has no teeth?
Yes.
Okay. Well, I wouldn't give her an absolutely no, you can't have dental implants. I'd tell her that there's probably an increased risk of ONJ, but my expectation is that it's very small.
When you say increased risk, can we quantify this?
Well, if you look at what we've reported in our paper, maybe somewhere between 1 in 10,000 to 1 in 100,000 person years on oral bisphosphonates of having a risk of ONJ, and we don't really know how many of those or what percentage of those people that would develop that have had any kind of minor oral surgical intervention. But I wouldn't be reluctant to provide her with 4 dental implants, everything else being equal.
So would you try to reassure the dentist, or?
Yes, I would.
Do you reassure the dentist, or would you ask the patient to find another dentist who will do it?
Well, you know, when Marx's article first came out in 2003, we were inundated, as many oral surgeons were, with phone calls from local dentists. They were now frightened to death to take anybody's tooth out that needed removal because of this report. And in fact, we tried to reassure them that our impression at that time was that the likelihood of someone on oral bisphosphonates or other anti-resorptives was going to be very unlikely to develop ONJ from having minor oral surgery done.
Thank you. Thank you.
You're welcome.
Can you, just very briefly, can you maybe highlight the difference between ONJ developing in a patient with osteoporosis and one who's got neoplasia and is on high dose of bisphosphonates?
Well, I think the main difference is the likelihood of developing it. We think that people on bisphosphonates or denosumab run a risk, according to the reported literature, of somewhere between 3 and 15% of incidence of developing ONJ. And in our local study that we did here in Halifax, Nova Scotia, small cancer center, we prospectively followed patients in our cancer center that were started or had been on bisphosphonate at the time. There were no denosumab patients at that time, and our incidence was about 4.3% of patients developed ONJ. So even though it's higher than the oral bisphosphonates group, it's still a relatively low number.
Is there anything that would make you worry about the patient being more likely to develop ONJ than this particular patient? Are there any red flags that physicians should be aware of?
Oh, sure. I think if there are other comorbidities, such as diabetes, steroid therapy, any kind of immunocompromised situation, either due to a health concern or medication, that would be one thing. The other important thing would be their oral hygiene is going to have to be very good, or we would certainly like it to be very good. Many patients who have lost all of their teeth have had poor oral hygiene in the past, and we've got to remember that. Once you get dental implants in place, they're now put back in a situation where they have to be quite meticulous about their cleaning, and we do recognize that inflammation and poor oral hygiene leading to that can jeopardize implant therapy.
Thank you very much, Dr. Morrissey. Please feel free anytime to butt in. Has Aliyah joined us? I know she's got another function. Aliyah is not with us yet. Okay, Sandy, you're with us, I know. Are you there?
Yeah, I have a
great
comments.
You want to give us your views, Sandy, please?
Thank you. So there are a couple of things that we should appreciate when we discuss the prevalence and incidence of this disease process in our patients. One is, as Archie had mentioned, the prevalence and incidence varies depending upon whether patients have been treated with oral bisphosphonates for osteoporosis, intravenous bisphosphonates for osteoporosis, or they've received intravenous bisphosphonates or denosumab, also called Prolia for osteoporosis, and Exgeva for neoplasia treatment in the U.S., for the treatment of neoplasia per se. Because the dosings are quite different, the amount that is provided patients are quite different. And as Archie had mentioned, the incidence of ONJ in the population that receives higher doses more frequently, like in the patients with malignancy, have greater risk of developing this disorder. And there are many papers that have been published that suggest the longer duration, the higher dose, even with the oral bisphosphonates, the greater the risk. And this has been published from Kaiser Permanente in Southern California, Richel's group, and others. So there's a difference in prevalence and incidence based on all these factors, as well as how the patients have been followed. So Archie, you had mentioned that you had followed these patients prospectively, whereas much of the literature that has been published, they looked at this in a retrospective analysis. bisphosphonate or other oral bisphosphonates in the osteoporosis population, et cetera, et cetera. So that's why I believe there's such great variability that we see in the published literature of the prevalence and incidence of this disorder.
Aliyah, welcome.
Thank you. Thank you. I thought I was muted as well, so that's perfect.
I know you've it's a very prestigious function. Thank you for joining us.
Oh, my pleasure. Thank you.
Aliyah, I'm sure you've seen the case, and while you're waiting to reconnect with Sandy, do you want to give us your impression?
Yes. Well, you know, I believe it's a great case because it talks about common issues that we're all facing. And one of the points that we highlighted in our recommendations was that we want to look at the risk of fracture and stratify that risk and compare it to the risk of ONJ in osteoporosis patients. And if we look at this lady's fracture risk, we would, you know, classify it as a moderate risk of fracture. And whether she has ONJ or does not have a risk of ONJ or is not going to go for surgery, she would be suitable for a drug holiday at this point, having been on a bisphosphonate for more than 5 years. So she could probably go ahead and stop her bisphosphonate because she no longer requires it and probably will do fairly well. If we look at her risk of ONJ now that she's going to have some dental procedure completed, knowing that she's been on bisphosphonates for 8 years, what would be the role of stopping therapy? Assume that if she was a high risk of fracture, her risk of ONJ, as Archie and Sandy have mentioned, is very low. It's like less than 1 in 100,000 with oral bisphosphonates. And if she had other risk factors for ONJ, such as diabetes or poor oral hygiene, or she was on anti-angiogenic agents, then, you know, we could say that after the surgical procedure was done, we could withhold the bisphosphonate and allow those osteoclasts to start removing bone, allow the area to heal, and after closure with soft tissue, then possibly her anti-resorptive therapy could be reconsidered.
So what would you tell the dentist?
I would say to the dentist that they can go ahead and do the procedure, and I would say that wait until everything has healed before we reconsider therapy. And in this patient, if her risk of fracture is moderate, then I would probably see her 2 years later and look at her bone density and ask her if she's had any fractures. And if her bone density is stable and there are no fractures, I'd keep her off drug therapy.
And go ahead with the dental implants?
Yeah.
I have can you hear me now? Anyone?
Clearly.
Pardon me?
Yeah, we can hear. I can hear you.
Yes.
Excellent. So, Aliyah, hi, this is Sandy. It's good to hear.
Sandy.
Good to hear you. So you had mentioned, though, that you would stop the bisphosphonates, and I totally agree. Because of her improvement in BMD, she has had no fractures. She's been on treatment for 8 years. It is certainly time to consider a drug holiday and monitor her appropriately. The question, though, I have is in patients that you wish to continue bisphosphonate therapy. And you had mentioned, and it's certainly in the paper, this wonderful paper that you have both put together, that you would discontinue bisphosphonates temporarily for surgery, and then thereafter with total healing or resolution, then you would reinstitute bisphosphonates or denosumab or whatever anti-resorptive specifically you would be using. We appreciate that if you stop or discontinue bisphosphonate immediately, the serum level will drop, but we both know, or all of us know that prescribe these drugs, that there will be a recycling of drug therapy. And it really doesn't disturb the crystalline matrix that is full of bisphosphonate, even though you discontinue drug therapy and wait for a month or two. It's still going to be in the crystalline matrix, deep inside bone, that you're going to be doing surgical excisions. So do you really think that there will be a difference in potential outcomes by discontinuing therapy a month or so before surgical intervention or not?
And those are really good points that you've raised, Sandy. And I totally agree with you that there is long-term skeletal retention of the bisphosphonate. And we have no data showing us that we can decrease the risk of ONJ by withholding the bisphosphonate. But what we know is that people who have bone injury, there's increased uptake of bisphosphonate locally, and we know that in people who have had bone scans completed. At the site of the injury, there's increased deposition of the bisphosphonate. So the reason why the International Task Force felt that in high-risk patients it would make sense to withhold the bisphosphonate is because post-invasive oral surgery, there may be increased deposition of the bisphosphonate locally, and this may actually impede healing in a high-risk patient. Now, in someone who has osteoporosis and is at a low risk of ONJ, it may not be necessary to interrupt therapy at all if the bisphosphonate is required for skeletal health. And if it was necessary, then she could certainly continue with her bisphosphonate if she needed it for skeletal health. But in this case, which really illustrates the common issues that we see today, I feel that it would be quite reasonable to say, you don't need this drug anymore for your skeletal health. And it may actually enhance osteoclast function if we stop it and allow those osteoclasts to not be further impeded with enhanced local deposition post-op. So we would not stop it prior to surgery, but after surgery there may be increased deposition following the surgery. And that was the rationale why the task force felt that it would be a reasonable recommendation to make only for high-risk patients for whom the risk of ONJ warranted a cessation of therapy.
But isn't there a debate in regard to bisphosphonate effect directly on angiogenesis and other factors in regard to a specific bone healing?
Absolutely. We still are not fully aware of the pathophysiology that results in ONJ. We know that suppression of bone remodeling is a significant factor, but infection and inflammation also play a big role. And we also believe that bisphosphonates in very high doses may inhibit angiogenesis, and this may be one of the mechanisms for the development of the ONJ lesions. They may be also immune modulatory effects of these drugs. So there may be multiple mechanisms whereby these drugs contribute to the development of ONJ. So in a patient who is at a high risk of developing ONJ, we felt that in the absence of evidence, it would be best to be cautious. And we felt that if the risk of ONJ was high, and in the paper we wanted to emphasize that we need to stratify risk and weigh the risks and the benefits. So if the risk of ONJ is high and the need for the bisphosphonate is not significant, then by all means we should stop therapy. If the risk of ONJ is high and the risk of fracture is also high, then potentially the patient could be switched to something such as teriparatide. Although we have limited data, it is anecdotal case report data. We have seen data showing us that teriparatide may hasten the healing of these lesions. So if someone has a high risk of fracture, that would be an appropriate intervention if there are no contraindications to teriparatide therapy. If someone has a high risk of fracture and they also have an increased risk of skeletal-related events from malignancy and they have a high risk of ONJ, in that situation, teriparatide clearly would not be a suitable option to consider. And in those individuals, possibly the bisphosphonate or denosumab could be held after the surgical procedure to ensure that there is optimal osteoclast function. And after the healing has taken place, and Archie, please share your experience, even in oncology patients, these people have been able to resume anti-resorptive therapy with good results.
I wonder if Archie could add his own society's take on that from the standpoint of the American Association of Oral and Maxillofacial Surgeon position paper in 2014 on continuing bisphosphonates. and the American Dental Association. I wonder if you might comment on their positions on discontinuing or continuing bisphosphonates.
I'd have to, the ADA position would follow Amos, I believe, but the American Association of OMF, I don't believe they recommended a drug holiday as they did in their first paper, and we certainly didn't in ours. I'd have to review that just to make sure. I did read that paper when it came out, but I don't think they are recommending a drug holiday. Do you remember, Leah? And that's
yeah, they really did not recommend a drug holiday for osteoporosis patients, and we felt that in view of the data that we have, we had a very lengthy discussion regarding this, and we felt that those people in whom ongoing therapy is not warranted for skeletal health, if they are going to be suitable for interruption of therapy because their skeletal health no longer requires it, this would be an opportunistic time to go ahead and proceed with a drug holiday to ensure that we have optimal osteoclast function. We all recognize that the risk of ONJ with bisphosphonates may only be maybe increased only slightly over the background population's risk. And so it's a small increment in risk. But in someone who has other risk factors, and they may have poor oral hygiene, dental abscess, steroid use, diabetes, those risks may add up. And in such an individual, stopping bisphosphonate therapy may be wise. And that is the reason we made that recommendation. And we also clarified that the evidence is very limited, and this was the consensus that we had around the table.
Leah, one of the questions we've been having here is, what about bone markers? Do you think they've got any role to play at all in deciding whether to continue or stop or to proceed with the implants?
And that's a really great question, Ron. And we looked at all of the data with regards to the use of bone markers and predicting the risk of ONJ. And Marks and colleagues had recommended that an individual who had decreased CTX values would be at an increased risk of ONJ. However, if you look at all of the data with zoledronic acid, we can see that the vast majority of these individuals do have suppression of biomarkers. However, there were only 2 cases of ONJ seen. One was in the placebo group and the other was in the zoledronic acid group. And individuals who are on bisphosphonate therapy will have suppression of bone remodeling. And we felt, looking at all of the global literature, that there was inadequate evidence to document that biomarkers would be of any benefit in predicting who is going to develop ONJ. There will be suppression of bone remodeling in all of the patients on bisphosphonates, yet ONJ continues to be a very rare event, with less than 1 in 100,000 individuals developing ONJ, fortunately. And the data that we presented in the paper, specifically with the zoledronic acid, looking at all of the randomized controlled trials evaluating zoledronic acid, there was no possibility of prediction of who was going to develop ONJ based on CTX.
So in fact, doing the CTX or any of the bone markers is essentially a waste of money and time.
Yeah, I would totally agree with that, because the biomarkers are going to be a reflection of total body remodeling, and the impact of the changes in the oral cavity are going to only contribute to a very small percentage of total body bone remodeling. And as anti-resorptive therapy lowers the biomarkers by about 50%, the biomarkers are not useful in predicting the risk of ONJ in the management of such patients.
I've got a question here both for Dr. Khan and Dr. Morrison. And the question is there a low level of bone markers, say CTX, below which you would refrain from doing the implants?
No. We don't even measure CTX levels.
at all. Okay.
We think it's too variable, and I must say I've learned more from Aaliyah and my other international colleagues on CTX, but it's too variable, and there's no proof that it predicts anything, so we don't consider it of any value at any level.
Okay, thank you.
Let me add that from the standpoint of the American Association of Oral and Maxillofacial Surgeons and the American Dental Society, that they have also come to that same conclusion. So the two other American societies do not believe that there is any reasonable association between the development of ONJ and the markers that you would potentially order just prior to surgical intervention.
I'd like to open the discussion now to the participants. I've been getting a few questions every now and then, but please do feel free to butt in any questions from the participants or comments.
Okay, this is Mandy. If you have a question, you can raise your hand, and I will unmute your line, and you can present your question to the panel.
While we're waiting for the question, Archie, I've got a question for you here. Can you give us an idea about what is the natural history of implants? How long do you expect them to last, and anything that we need to be concerned about?
That's a good question. So implants are, once the implant osseointegrates with the bone, and that's the magic of those things since they were first developed, is that there actually is a true integration with the surface of our own cells. Once that happens, it's intended to be a permanent relationship between the bone, soft tissue, and the implant. We now recognize one of the big ongoing problems with dental implants is peri-implantitis, which is almost like periodontitis, although the majority of implants are not prone to that. Some patients will experience that, so there can be bone loss around implants. That usually tends to start occurring early on and then is progressive, so people may lose implants later on. Surfaces have been improved significantly, so many people who get dental implants can expect to have them for the rest of their lives. The first gentleman that was treated in Sweden in 1965, he died with his two dental implants in place not so many years ago in the 2000s. So there is theoretically a lifetime longevity of these things to function.
Thank you. Thank you.
You're welcome.
I guess I have a question for the panel, if you don't mind. Ron?
Go ahead, please. Please go ahead.
So one of the basic differences between the task force, the ASBMR task force, and the American Association of Oral and Maxillofacial Surgeons is the staging of the disease in regard to stage 0, meaning those individuals that do not have exposed bone that may have symptoms. And it is stated that in their experience, in our oral surgeons and dentists experience, that and the publications that have been listed, that about 50% of these patients, without the full-blown definition of ONJ, proceeds to ONJ through stage 0, meaning they don't have a open wound, meaning a direct, either through fistula or direct observation, exposed bone. And so I guess I'd have to ask how the task force came to the conclusion that they would not wish to consider stage 0 in their preemptive diagnosis, meaning prior to the defined end stage of ONJ when there is exposed bone, fistula, and the other aspects of the disease?
Well,
Archie, do you want to take that one? That's a good question, Sandy.
well, it is now for me. I think that if you use stage 0, you're going to have a gross overdiagnosis of ONJ. ONJ, by definition, is exposed bone. And if it's just a fistula that presents, if someone has, let's say, almost like a sequestrum submucosally, and it presents first as a fistula, that for me is ONJ. That's exposed bone, because if you look at a small enough level, you'll see bone through that fistula. But to start diagnosing patients with stage 0 ONJ just because they're on an antiresorptive and because they have symptoms is going to grossly overdiagnose the condition. That's like saying that someone, that I have stage 0 heart disease. I suppose I do, even though I haven't had any heart symptoms. But it would grossly overdiagnose it, and the about 50% that some people talk about is just that. It's about. There's no conclusive evidence or good data showing how many patients actually have symptoms that go on to develop ONJ. And especially in the jaws and the mouth, there are so many people that have aches and pains or dental-related issues, periodontal-related issues that could really be misconstrued as possibly they're going to develop ONJ because they're on a bisphosphonate. So I think you've really got to wait till you have the disease occur, then they've got the disease. So for me, it was an easy thing not to support a stage 0, because what does stage 0 of anything mean? If you haven't developed the disease, you're guessing. It's like saying someone that's a smoker has stage 0 lung disease, lung cancer. If they have no objective findings of any incipient lung cancer lesion, they don't really have lung cancer, but they're susceptible to it. So it doesn't make sense to me to call anything stage 0.
Leah, would you agree with that?
Yeah. So, Sandy, you really opened the can of worms, because we had a very, very long debate, and I personally agree totally with Archie, but there were members on the task force who were also leaders of other international societies and had proposed that stage 0 be included as an important stage in the ONJ classification. And the final bottom line was that we agreed to disagree, and this was one area that we were not able to achieve consensus on. And that's how we phrased it in the document, that certainly a large number of the task force agreed with Archie and myself that we felt that calling the stage 0, including conditions which may or may not develop into ONJ, would result in over-diagnosis, over-categorization of this condition. And we felt that it may do more harm than good. And we also felt that our understanding of the pathophysiology is very limited, and the evidence is very limited. So we didn't want to overstep the state of the science. And so that was really our view, that we didn't want to go ahead and label something that we weren't sure would, in fact, become that condition. And so that's the reason why we felt that stage 0 would be a little bit preliminary in view of the evidence that we have today.
So let me ask, on a practical basis, a patient comes into either of you two, and either referred to the oral surgeon or dentist, or directly to you as their treating physician, and they've had significant pain in their jaw for 4 weeks. You can't find much inflammation on palpation, internally, externally. There's no obvious redness, but they have pain. And how would you, and this is chronic, they have reasonable dental hygiene, they've been seeing their dentist, oral surgeon regularly, so there is no underlying major problems. How would you follow those people? Would you just whisk them out the door? How would you follow them in the long term to be sure that this doesn't develop, as our colleagues in oral surgery and dentistry suggest, staging them as 0 and following them? How would you do this?
Well, if in the exact scenario that you gave, where there's absolutely nothing to find, I personally would schedule them to come back in 6 months, but I would closely educate them as to what to look for and to get back in touch with us should anything develop, like a swelling, a draining fistula, anything untoward that they're not experiencing now. And that's assuming that they're not a chronic pain type patient, because there are loads of people out there that have chronic pain in their jaws that there's absolutely nothing to find, whether it be a temporomandibular disorder or otherwise. But in the exact scenario you suggested, I would see that person in 6 months and probably take another radiograph.
Do you expect to find any changes in the radiographs in stage 0?
Well, I don't believe in stage 0s. But if you have someone, let's say that person presents and you take a radiograph and they have some sclerosis, some sclerotic bone around a lower molar or even in the edentulous area. That might be a site that you might want to monitor very closely, or you might elect to do a bone scan or some other more detailed images like a cone beam CT or even a CT scan, medical grade CT, just to investigate a little further to see if you can rule out that it is a pathologic lesion or not. But you wouldn't. You'd certainly be more suspicious of a finding like that, a radiographic finding.
Is it likely that the Orofacial Maxillary Surgery Society will change their classification?
Which one, the American?
The Orofacial Maxillary. Yeah.
Yeah, the American one. I more or less represent the Canadian Association. One of my colleagues that I work with is actually on that 2014 paper, and it was kind of a surprise to me because I didn't know he had any interest in ONJ, but they just wanted a Canadian representative. In any event, I don't know if they'll change or not. They changed on the drug holiday, but and on the CTX, I don't know if they'll change or not.
Okay. Aliyah, what about the ASBMR? Have they taken any position on this?
So the ASBMR is basically we are representing the ASBMR as well, and the ASBMR was a member of our task force. And our document was reviewed by the Scientific Advisory Committee of the ASBMR, as well as the other organizations which endorsed our document.
Okay. Sandy, what about IACD?
I don't believe, Ron, that there's any position on this.
Okay.
I think that just to finalize a point, I think any disease process starts somewhere. I think what we're seeing with ONJ is a very obvious disease, but it has to start somewhere. And the real issue in the future will be to distinguish those patients that have early disease from those that do not by other imaging techniques or other easily identified measures, so that our patients can be treated potentially earlier than later. And I think that's an important issue.
I've got a question. Thank you, Sandy. I've got a question that came up here. The question is, what is the difference between ONJ and the dry socket after tooth extraction?
Well, dry socket is simply it's a breakdown of the clot in the early healing phase, which basically denudes the inner socket of its granulation tissue, healing tissue, and early soft tissue migration. It presents 3 to 5 days after. It's the best working theory is that it is related to an infective process, but not an acute, purulent, separative infective process. Very easy to treat. It's self-limiting. Does not lead to, exposed bone for the length of time needed to diagnose ONJ. In the very early stages, if you looked in there, yes, you could see some exposed bone in the socket, but not wound breakdown outside of the socket as you get with ONJ. So it is quite an easy distinction to make.
Thank you. I've got another question here, but it's concerning the 8 weeks that the bone should be exposed. How essential is that?
Well, good question. That was the original sort of time frame that was proposed, and everybody seems to agree with it. And it seems reasonable because 8 weeks is a long time for someone to have exposed bone, even if they have delayed healing, to have exposed bone. Now that's in the absence of a bony protuberance over, very thin mucosa, like someone may have a mandibular exostosis that gets traumatized, and I think we're not considering that person to be mixed in with the ONJ group. But it was, I don't know who first came up with that length of time, but it seems reasonable just based on the premise that well before 8 weeks, any exposed bone area should be healed over, and it seems like a reasonable time frame.
Thank you.
Just for the sake of clarification, Archie, we're talking about exposed bone, either directly exposed or through fistula, correct?
Sure. Although, if somebody, you can get fistula from osteomyelitis. Sure. Which is a different process, but yes, I think if somebody that hasn't had an intervention, that is, or has had an intervention, is on anti-resorptive therapy, and develops a fistula before they develop frank exposed bone, in the absence of a retained root tip or a piece of bone that was left behind from a surgery, anything like that, that for me does constitute stage 1 ONJ.
Does that also include extraoral fistulas, as we see in some of our patients that have had long-standing disease?
Yeah, so those presumably would fall under the classification of stage 2. So you would expect them to have have a stage 1 presentation with frank exposed bone first, that then went on to lead to that.
Mm-hmm. Thank you.
Any other questions from the participants?
I have one question, if no one else does.
Go ahead.
Yeah, one of the questions I have for Archie is there's some literature, some oral surgical literature suggesting that prior to surgery that antibiotic therapy be utilized prior to and after surgery, and they have seen a significant decrease in ONJ occurrence, and this is especially in the oncology patients. Have you seen this, or do you agree with this or not?
I agree with that, yes. In this group of patients, I think that, we know that there's a good bacterial load that they're going to get into the wound from their oral cavity. So anybody that has ONJ, or even if you have a bisphosphonate patient, I'm thinking more of the cancer patient that's on the regular bisphosphonate or denosumab, I think it's reasonable to cover them with antibiotics, prophylactically as you would for, someone else that you think is more susceptible to an infection. I think that's a reasonable thing to do, yes.
Would you do it in patients who are on oral bisphosphonates for osteoporosis as a prophylactic prior to implant surgery or anything like that?
I personally do not. Implant surgery, I do use prophylactic antibiotics even in healthy patients. If you look at the literature, there are many studies that suggest there's no difference in infection rate, but it still is a foreign body, as biocompatible as it is. I do use a prophylactic antibiotic even in healthy patients for dental implants. For a simple extraction, even in a patient with an abscessed tooth that's on oral bisphosphonates, no, I do not use oral or antibiotic therapy.
When you use antibiotics, how long would you continue?
I would, if I'm going to use a prophylactic dose, I'll give them a large prophylactic dose, 30 to 60 minutes before a procedure, depending on how it's administered. Or I would put someone on a 7 to 10 day course, which is kind of the typical prophylaxis we put on someone just to get them through their early healing and some mucosalization of that wound.
Thank you. I've got another question that came up here. It's about hyperbaric oxygen. Any comments on its use for ONJ?
Well, don't have any experience with hyperbaric oxygen in ONJ. It's been a very controversial topic in our literature. For years, there was a gospel written about hyperbaric oxygen, and the dental world seemed to follow it religiously. And a large public health study in France really brought that into question. And many of the large cancer centers in the U.S. have abolished hyperbaric oxygen therapy pre and post dental extractions in their radiotherapy patients, head and neck radiotherapy oncology patients. And so a lot of the original evidence that was out there has largely been refuted, and much of the world now, and I can't speak for everyone, we certainly do not put patients through hyperbaric oxygen therapy for osteonecrosis prevention anymore. And for ONJ, someone would have to convince me pretty strongly that there's going to be a beneficial effect before I would use it in ONJ patients. Any of the patients that I've operated, we haven't used hyperbaric oxygen therapy. And in most of the reports that are out there that oral surgeons have operated these patients with good success rates, they haven't used hyperbaric oxygen therapy. I know that people are looking at it, but I'll wait to see the real good evidence before I think it needs to be used.
Thank you, Archie.
Okay.
I see, Sandy, you were going to say something?
No. It's just interesting to hear the differences between the American Oral Surgical Groups and the task force, the consensus task force, because there are significant differences. The listeners on our call should appreciate the significant differences as we've talked about stage 0 versus 1, 2, and 3. They're emphasizing even treatment in stage 0 with antibiotics and things like that, a more aggressive attitude. And in other ways, the American Association of Oral Maxillofacial Surgeons believe that biochemical markers and other things are no better than anything else in diagnosing this condition, or to stop drug therapy. They don't believe in stopping drug therapy as they did before. So it's very interesting how the entire field is moving, and it's diverging in some aspects and converging in others. And I wonder if Aaliyah has any comments regarding that.
Those are very, very valuable observations that you've made, Sandy, and I think it's really a reflection of the fact that there's limited evidence, and you're really seeing opinion, and opinion can vary, especially when the evidence is so limited. So, when we see more evidence becoming available, I think that we're going to see more convergence on a lot of these issues.
Thank you.
Thank you.
I've got another question here. It's gone. One of the key words were, what about resection?
Resection?
Resection.
Resecting.
So I haven't had time to read the whole, it's because about 4 lines, but it said what about, the essence I think was about resecting the necrotic area.
Okay. So when we first all learned of this, we were gravely warned not to operate these patients, that they could get much worse and you could put them in a much worse state. But all of us were eventually faced with patients that either their oncologist, they either had symptomatic lesions that something needed to be done about. And in my experience, anyone that we have operated so far has been done successfully. And we basically treat it like an osteomyelitis type lesion, where you resect the affected bone down to, healthy appearing bleeding bone, remove sharp edges, get good mucosal coverage over that with good suturing, and they've gone on to heal. Remember that the vast majority of these patients are probably seen by dentists who work in hospitals and work closely with oncologists and manage most of these patients conservatively with mouth rinses, scrupulous oral hygiene, and following them along closely, treating them with antibiotics symptomatically. I think many of these patients can be operated, particularly if they have a significant enough lesion. It's surprising how many of these patients are pain-free and functioning comfortably, even though they've got a centimeter or more of exposed bone through their mucosa. It was interesting to me when Lee and I were down in Texas a year and a half ago at one of the meetings. I was inundated with questions. The oncologist down there and the endocrinologist could not find oral surgeons or dentists to extract teeth in patients that were on these medications, and it was driving them crazy. They couldn't believe that I was talking about doing these resections, and there are many reports in the literature with good numbers of good successful outcomes of resecting these lesions. So we don't shy away from that like we once did in the early years before we really didn't know anything about it.
So do you need special training actually for this, or can any good oral facial surgeon do it?
I think it's very minor surgery. I think any oral surgeon should be able to do it. As with many specialties these days, there are so many oral surgeons that just do very limited, routine, minor oral surgery. They don't want to be involved in these kind of cases. So I suppose that's fair enough. There should be lots of people around locally that they can refer them to have it done.
Thank you. I'm going to ask our 3 panelists to do some concluding remarks in a couple of minutes. I see in the audience we've got Sarah Morgan. Sarah, I don't wish to put you on the spot. Anything you'd like to say?
Just one moment and let me unmute her. Dr. Morgan, are you there? Dr. Morgan?
Okay, I think she's done. I'm going to ask our 3 panelists to do some concluding remarks. Time is running out. It's been a very lively discussion. Thank you very much. Archie, shall I start with you?
Well, firstly, thank you for inviting me to participate in this. I think the bottom line for me is that if medical oncologists, and I say them because of the relative incidence being so much higher in that group of patients, but if they feel there's a good reason to have these patients on their anti-resorptive therapy, then I think they should not fear ONJ. If it's present, have it treated. If they're concerned about the exposed bone and think that their medication is going to make these patients worse, have it treated. They shouldn't be fearful of that. I think it's more important. I think the risk, my present day feeling is that the risk of getting a worse situation or causing ONJ versus the benefit of them being on their anti-resorptive, I think it's worthwhile to do the surgery, get them back on their anti-resorptive, and get on with their care.
Thank you. Aliyah, you have a go? A few concluding remarks?
Yeah, sure. And I agree with Archie. I think that, as we've learned more about ONJ, we recognize that there are many important preventive steps that we can take to prevent ONJ. We need to identify those people who are at an increased risk of ONJ and initiate preventive measures such as the local antibiotic mouth rinses and also systemic antibiotics for high-risk patients, and consider interruption of high-dose bisphosphonate therapy, especially for oncology patients with multiple risk factors for the development of ONJ. And if we target appropriate preventive action for high-risk patients, then I think we can make a difference. And it's important also to ensure that patients recognize that this is not a common condition, and they do not need to be afraid of taking osteoporosis therapy, because osteoporosis therapy provides them with so much greater benefit, and the risk of ONJ is very small, and we can act on preventing ONJ in this patient population.
Thank you, Aliyah. Andy, you got the final words.
Thank you, and I appreciate being on this call, and it is certainly wonderful to discuss this with Aliyah and Archie. This is fantastic. Couple things just to remind everyone that the medications that we use, whether it's oral or in some cases IV bisphosphonates in the non-neoplasia population, we also use these drugs in Paget's disease. Some of us have used it in fibrous dysplasia and other skeletal phenomena. So we have to really be aware that it's beyond just osteoporosis and malignancy that these conditions can arise, and we have to be just aware of those and discuss this with our patients, because it's really essential as the prescribing physicians that we are, that we fully appreciate the early and late manifestations of ONJ and evaluate our patients when we believe that they may have early manifestations, because we're the ones that know our patients. We understand our patients. We see these patients over and over, year after year, and if they do have concerns or they have significant pain, even without significant signs at that time, we should be aware that they need to be followed potentially more closely than other patients. It's also essential that we partner with our oral surgeons and dentists. So this is a multifactorial disease, and we have to partner with the patient and their oral surgeon and dentist prior to initiation of our medical therapy. So I think this is really a key issue. So everyone's on the same page. We monitor our patients. We treat them appropriately. They understand the risks, and this is really an important issue for me and my patients. And that any invasive oral surgery be considered prior to institution of these medications. So that means that if we know we're going to be on IV bisphosphonates, we send our patients to our oral surgeons and dentists to review the situation, to perform any surgeries that have to be done prior to our medical therapies, and to consider different bisphosphonates, depending upon, or Prolia, for those patients that may be at high future risk for surgical intervention. Maybe not right now, but in the future, because we all know that denosumab is a little bit different than the oral and IV bisphosphonates that are given over an extended period of time. And denosumab's effectiveness wears after 6 months, meaning after you provide the patient with denosumab, you wait another 6 months, there's a rebound effect within that next 6-month period. So maybe a preferential drug for some patients that may require significant intervention in the future. And I want to thank you again for allowing me to participate in this discussion. Thank you.
Thank you very much. It really has been my privilege to have 3 outstanding people collaborate with me on this program. Aliyah Khan, Archie Morrison, and Sandy Bain, it really is a pleasure working with you. Thank you very much. Thank you for sharing all your experience. I'd like to thank all our participants, and please do fill in the evaluation forms. They're very important so that we can tailor future programs to your particular interest. And finally, I would like to thank very much Mandy. Mandy, you've been terrific. Thank you very much for everything you've done. And Randy Glick, thank you for allowing us to do this program. Have a wonderful evening and a happy long weekend. Thank you.
Thank you.
Good night.
Thank you. Good night.
Good night.
Thank you, Ron, for a great program.
Thank you. Good night.